Thank you so much, Tricia, and good morning, everyone. Happy Friday. Welcome. My name is Megan.
I think you muted yourself, Megan.
You know, I have tried to be so diligent with watching that. Thank you, Tricia. Okay, so welcome everyone. Happy Friday. My name is Megan Phillips. I am the Access Supervisor for Oakland Community Health Network, and with me today is Tradina Taylor. She's our lead access screener. Tradina, do you want to say hello?
Hello, everyone.
Thank you so much, Tradina. So today what we're going to be talking about is accessing services in network. I apologize. I was muted again somehow. So we are Oakland Community Health Network. We are the public mental health system for Oakland County. We're often referred to as the CMH. We're a community-based local public entity that manages specialty support and services to individuals with serious mental illness, serious emotional disturbances, intellectual and developmental disabilities, infant mental health, and substance use disorders. Most people who receive services through us do have Medicaid insurance. That's not the case for everyone. Every population that we service, we have some different caveats. We have some different funding sources. So it does differ by population at times of what specific funding sources that we have available. So our mission statement is to inspire hope, empower people, and strengthen communities. The number of people we service in our network is about 28,000. And of that 28,000, about 12,700 are adults with mental illness, 340 are with autism, 2,400 are children with serious emotional disturbances, and 4,200 are those with intellectual or developmental disabilities, and substance use disorders makes up about 7,800. So it's important that we give a little background on OCHN. So OCHN is the PIHP and the CMHSP. So a prepaid inpatient health plan is an organization responsible for managing Medicaid services related to behavioral health. We hold a contract with the state of Michigan, MDHHS, and we are responsible for arranging inpatient care. We also serve as a CMHSP, which means we either provide services and supports to people directly or through contracts with a provider network. So we have contracts in place with our core provider network. The CMHP is governed by a board of directors and managed by the PHP, and CMHSPs are fully accountable, excuse me, governmental entities which ensure people served in public participate, and the public participation is involved in the system decision making. So in the state of Michigan, we have 10 PIHPs and 46 CMHSPs. And so that's a bit of a lot of information to take in. The best way I can break things down for you a little bit, here in Oakland County, again, we're the PIHP and the CMHSP, which means that we are handling all the Medicaid services, all the accessing of services for higher level of care services, and we handle all the authorizations on the back end. There are 3 PIHPs, which are also CMHSPs. Oakland, Macomb, and Wayne, they are the three that are a CMHSP as well as a PIHP. And then the other 7 PIHPs, they have multiple CMHs underneath of them because they have multiple counties underneath of them. It's just important to know that information because every PIHP can operate differently. So if you are talking to a colleague who is in Ionia County, what their system looks like and how to access services will look different than how it is done in Oakland County. Every PIHP is very much tailored to their area of what the needs are, as well as operations. There's the standard set of guidelines that we all follow for operations, but then it's very much tailored on the back end for very more specific drilled down areas for services offered and things of that nature. So if ever talking to a colleague and they're telling you that their system operates differently, yes, very much possible. Okay, so our funding and service delivery paths. Our funding comes from MDHHS and Oakland County. So again, we hold the contract with MDHHS for the Medicaid dollars. We also received block grant funding dollars from the state as well. And then from Oakland County, we also receive funding. So that funding comes direct to us, and then we contract out with core provider agencies or direct service providers for the services to then go to the people. So when it comes to SUD, for example, with substance use disorder services, we have a multitude of funding sources we're able to utilize. So we assist individuals with Medicaid, HMP. For those who have no insurance, we are able to look at their income, see if they fall within guidelines for income eligibility. And then if so, we're able to step in and help assist their treatment funding with block grant dollars and help with any co-pays that are needed. Also, individuals with third-party insurance, say someone has a private insurance like Blue Cross Blue Shield, their deductible is $6,000, out-of-pocket max is $8,000. When we have someone with a third-party insurance, we ask for their benefits, we review them, we see how much their cost is out of pocket, because just because somebody has a third-party insurance doesn't necessarily mean that they are able to afford that insurance. And so when we look at what services they are in need of, and what they qualify for, we're looking at how much is that going to cost them out of pocket with their insurance. And if that cost is too much, we again will step in with block grant dollars as well. Let's see. Oops. Oh. So individuals served by OCHN providers are protected under HIPAA and or 42 CFR. So those are the federal laws that tell providers and others how they can share an individual's health information, including mental health. So it's very important to notate here when the difference between HIPAA and 42 CFR. 42 CFR governs the confidentiality of alcohol and drug treatment. It governs the confidentiality of substance use disorder treatment and prevention information. What that means is, in order for information to be disclosed, there needs to be a signed release for the person. And so with HIPAA, whereas verbal permission is able to be accepted by a person, 42 CFR does not allow that. 42 CFR says a person has to sign off and give permission for that. And it's always important for everyone to know that, because it can seem, and it can be frustrating at times, and I've heard that feedback before, that For one set of services, if it's mental health with a core provider, it was easier for someone to be able to obtain access to getting an update from the therapist, how things were going. And typically it is because a person's able to give that verbal permission for it. But with SUD, it all comes down to that hard copy signed release needing to be in play. So here at OCHN, our call volume that comes into our Access Call Center for October 2018 to September 2019, our total calls were almost 30,000. So we were at 29,988. And so that is a very large call volume. I think when we average it out and break it down, it averages out to be about 200 calls a day, give or take. It always depends. But what we do is our goal is to answer calls within 30 seconds. And that is one of the requirements that is in place for the NCQA accreditation. And my apologies, I normally like to have everything written out of what it stands for, but I don't have that with me right now. And so it's an accreditation that we've been able to obtain. We answer our calls within 30 seconds. And also our call retention, we're able to keep our calls and get to our calls in a timely manner. Okay, so our how our Access Center works, when somebody is interested in receiving services, one of the things that they can do is call our Central Access Center. Our phone number is up there, and as well as the hours in which we operate. And so what occurs is a person calls our main number, and the phone is answered by someone that is called a referral specialist. Our referral specialist will then ask the person name, identifying information, social security number, and we'll ask the person, what services are you seeking? Sometimes a person might not know offhand. They might say, well, I'm trying to figure out what is out there. Our referral specialist will walk them through based on questions that they're asking. They'll, ask them things like, are you looking for mental health or substance abuse? Is it for children's services? Once we have an idea of what they're looking for, then we drill down a little further. So if someone's seeking SUD services, we will ask them, okay, are you seeking higher level of care or standard outpatient? So we have all these decision points along the way based on the questions we're asking to be able to help and give people answers and resources of what steps they need to do to access those services. Or if they are seeking higher level of care services, then we go through income eligibility. What is your insurance? That's where we identify, does somebody have Medicaid or no Medicaid? What is your income? Is there that third-party insurance that we talked about earlier? And that's where all those steps come in, where we say, okay, this is what you're looking for. We may have to connect you with our RISE Center, which has our case managers to help pull your insurance information. But our referral specialist, I refer to them as the hub and the heartbeat of everything that we do, because they're the ones who are triaging those calls, finding out what the needs are, identifying if the person, are you on probation or parole? Are you pregnant or are you injecting? We do have priority populations that we service at times. And so they are the ones who do that drill down to find out and gather all the information. So if they do qualify for a screening, or if more paperwork is needed based on some services, paperwork has to be submitted by the federal guidelines. So that way it's a part of how they qualify for services. That paperwork is needed. They'll go through with the family. Here is the paperwork that's needed. Here's how you can submit it to us. And so they go through all the steps that are needed for everything. Once somebody qualifies, they will then schedule them for a screening with the actual screener, and then the screener follows up with the person on their either scheduled time, or if we do have a live screener available right then, we'll conduct the screening on the spot. It sometimes just depends on the call volume and what's occurring right exactly at that moment. So with that, I'll pause for a moment and see if there's any questions in the chat.
We don't have any questions yet.
Perfect, thank you. So in terms of substance use disorders, in previous webinars, we went in depth into all of the services that are offered. So here with this webinar being more about accessing services, I'm going to talk more about how to access these services. So at an outpatient level, if someone is seeking outpatient, the case management, peer recovery coaches, recovery housing services, what we refer to as lower level of care services. That is accessed directly at the provider, our outpatient provider network. That does not require an access screening. So a person does not need to come through our main access center. Now, if someone does call us and they tell us I'm looking for outpatient substance abuse services, and we ask what type of insurance do you have, so that way we make sure the provider list we give them is in line with their insurance. If they say I have Medicaid or HMP or no insurance, we will provide them, we'll ask where is it you would like to attend, you know, what city are you looking at. We ensure we give them at least 3 outpatient providers that are close to them. And we let them know that they're able to contact that outpatient provider directly to request those services, set an intake appointment, and begin those services. When it comes to things like the third-party insurance, things like that, all of that is handled at the outpatient level with those providers. So we have a process put in place with all of our outpatient providers behind the scenes. If they have someone with third-party insurance who comes through, they're not able to afford it, they submit a request to myself with that release of information, and I review the insurance, and then I identify, yes, they would qualify. Yes, we're able to step in and assist with block grant funding. Let's see, for our higher level of care services like medication-assisted treatment, withdrawal management, short-term or long-term residential treatment, those services do require an access screening. And I also want to touch on, because medication-assisted treatment, yes, it is an outpatient service, but it is a higher level of care outpatient service. So yes, an access screening, referral and authorization is needed for the person. So I always like to make that distinction for some people, because it can get a little tricky. It is an outpatient service, but it's a higher level of care outpatient service. So those services that are higher level of care, again, the medication-assisted treatment, withdrawal management, residential, those require a person contact our main access number. And when they call that main access number is when, again, the support staff will go through the questions. What service are you looking for? And they will ask about insurance. And then they will schedule them for their access screening. When we screen the individual, we then identify the level of care that they qualify for. And for when they qualify for one of those higher levels of care, the access screener is setting the person up for that initial intake appointment. With this being a time of COVID right now, we had to change some of our processes on the back end, and we are still assisting individuals with connecting them to the provider for that intake appointment. However, there are times, because SUD moved to phone screenings at this time to stay in line with the governor's stay home, stay safe order, Because of that, at times, we don't always have a signed ROI between us and that SUD provider. So when that happens, we three-way call the provider. We say, hi, provider, this is Megan from Access. I have someone here on the phone. Please assist them. And then we drop off the line. So the setting up of the actual intake appointment is occurring between person and provider, but we are able to do that warm transfer to ensure that they are connected.
Megan, we have a quick question.
Yes.
Brianna asks, what disqualifies a person?
I guess I just have a quick follow-up. Disqualifies a person from receiving outpatient services, or disqualifies them from receiving a service in general, or funding. Is that what it refers to?
I'm not sure. Brianna, are you able to add in the chat to clarify your question?
A service in general. So really, the only thing that would essentially disqualify for a person for an SUD service is if the person is outright saying, if they go to an outpatient provider, whether it's an order of probation or something of that, person goes to outpatient provider, person says, I don't have an SUD problem, period. I've never been arrested for one. So it typically doesn't happen like that often. At the outpatient level, what occurs is when a person sets their appointment with an outpatient provider, when the person arrives, or right now during COVID, we're doing telehealth at the outpatient providers. But when a person goes to their initial intake appointment, that's when they have a full assessment. That is when the provider is going very in depth with the person about their history. What have you been arrested for in the past? What, were you under the influence at any time? What is the crime related to a substance use disorder in any way? Just because a person might not have a DUI, they might have retail fraud charges, and those retail fraud charges are directly stemming from the fact that somebody was stealing to support their habit. So that's when they start to really do a deep dive and ask all of those questions. So at an outpatient level, they do that full assessment. Outpatient offers many different levels of care. So you have outpatient that can offer early intervention services, standard outpatient services, and intensive outpatient services. And then between outpatient and intensive outpatient, we have something that's also called enhanced. Maybe someone who doesn't quite qualify enough for IOP, they need a little more than standard outpatient. So sometimes somebody might come in for an initial outpatient appointment, and it's really unknown yet. Is there a substance use issue? Is there not? It might take a few sessions for the provider and therapist to work with the person, work with them therapeutically, build that relationship. That might be more of early intervention to start. And so when it's early intervention to start those services, after maybe 3 or 4 sessions, more might come out about how much they've actually been using, how often. And that's when a therapist is able to say, okay, I'm comfortable being able to give now that diagnosis of dependence. And yes, I think we do need to engage in more of an outpatient type service.
We have a couple more questions to follow up with that, Megan.
Yes.
Michelle says that they seem to have several people on probation that are advised that they don't qualify for services. And this is happening when a judge sentences a person to complete mental health services.
So in terms of mental health, Tradina, would you like to answer that one?
I sure can. So you're saying, just so I can make sure I'm clear here, Michelle, that the judge is saying that the person is sentenced to complete mental health services. So I'll kind of go into detail regarding that. But let's say a judge say that someone needs to complete mental health service. As Megan said, they will call the access line. They will talk to one of the referral specialists. The referral specialist will collect the information. So we screen at OCHN for a higher level of services. So when we do a screening, that's someone with a severe and persistent mental illness. We look at different tools that look at the level of functioning to see if they qualify for that higher level of services. Now, let's say they don't qualify for that higher level of services. We don't just send a person on, we do still connect them with services. And we do still have providers that will work with an individual on a higher level of services through OCHN, but there's also providers that will also see the person for mental health services on a lower level. So that I hope that helps answer the question a little bit. They can get services. It's just we kind of like how Megan said, we screen a higher level. So for substance use is a higher level, and as well as for mental health, it's a higher level of service. And let me know in the chat if that clarified or if I need to add on to that.
And I believe you'll touch on that a little bit further in the webinar, right?
Absolutely.
Okay. So I'm going to have one question before we continue with the SUD services, Megan.
Sure.
Somebody is asking that if they have a spend down with their insurance but are unable to pay before and after the pandemic.
So when it comes to SUD like SUD and mental health with spend down are different. So in terms of SUD services, when somebody has spend down and when we run their insurance and the insurance will tell us that spend down has not been met for the month, that means that their Medicaid is not active, which means that we then are able to identify what's their monthly income. And based on looking at their income, we look to see, do they qualify for funding then under block grant services? If they do, if they have met their spend down, then they do have the full Medicaid in place. I know that my understanding and I only know a bit and piece about this. I believe my understanding is that during this pandemic right now, that if somebody meets their spend down, it's being continued to show active during this entire pandemic. And it's only 30 days after it is deemed the end of this emergency that they would then lose that. So in regards to mental health, if somebody calls Access seeking the higher level of care, someone with severe and persistent mental health, they call Access seeking services, and we look at their insurance and we find that they have spend down. We never deny anyone the ability to have a screening. What we do inform everyone of is, and we let them know with having spend down, if it's showing that they have not yet met that spend down amount, that they might not, that they are first responsible for the costs of the services out of They are responsible for the cost out of pocket for the mental health services at one of the providers. If they have met that spend down amount, then we let them know you can start to engage in those services. We can screen to find if you are eligible for those services, but please be aware with that spend down, 30 days after this pandemic ends and it's deemed non-emergent anymore by the governor, you will lose the spend down, you will lose the full Medicaid, and it's going to go back to you needing to pay the cost out of pocket monthly. So we have those conversations up front with the person, so that way they're very well aware. On the mental health side, if somebody has spend down and they're looking to engage in mental health services and they don't wish to have to pay those costs out of pocket, one of the services they can be connected with is our CCBHC, and we have 2 providers that engage in that. And so Tradina will go into that more on the mental health side when she goes into those services as well. Also good information for you to know in terms of women's specialty services in terms of substance abuse. This is touching a little more back into information I had touched on specific for SUD in the last webinar, but it's always helpful, and I think it's always so important I touch on this. We have some providers that are state designated treatment services for pregnant women, women with young children, men, and the person who is the primary caregiver. So if I have somebody who is pregnant, they are in need of detox or residential services, I have a very specific provider that takes that individual because they need not only the high level of care substance abuse treatment, but then they also need to be able to have that medical follow-up and prenatal care follow-up as well. Also at an outpatient level, we have Oakland Family Services. It's a PRISM program. It is a program for women or the persons who are the primary caregivers of the children. They offer daycare on site. So that way, when person needs to come in and have services, if they're the primary caregiver, and a barrier to treatment is that a person always has their children and they can't have somebody watch them, they can come in, be able to have their therapy appointment, and their children are able to be watched on site. So the Sober Support Unit, always good to know about this as well. It is ran by Common Ground, who's one of our contracted providers. It is located at the Resource and Crisis Center. It is open 24 hours, 7 days a week. It is specifically for individuals seeking higher level of care treatment. So an individual seeking detox or residential services, and when they come through, we are able to place them into that level of care within 24 hours. And then how are SUD services determined? This is always a question that comes up, and I think it's great to hit on. So what we use is the American Society of Addiction Medicine placement criteria. It's a comprehensive set of guidelines for treatment placement, continued stay, and transfer discharge criteria. So the ASAM consists of 6 dimensions. They're evaluated from every angle. We consider them separately, we consider them together, but essentially ASAM gives a clinician a very standardized way and questions to ask, clinical questions that are posed of what we look at to identify what makes a person appropriate for a specific level of care. So one of the questions that comes up quite frequently, or phone calls that we get coming into the main access line, is individuals will call seeking an assessment for SUD services. And so we always make sure we slow down and take our time with those individuals so that way we can fully understand what they're asking for. At the access level, we do not do assessments. We do screenings for higher level of care. And so for SUD services, the assessment occurs at the provider level. So when a person is seeking detox, residential, medication-assisted treatment, we are using ASAM to see if the person meets the criteria that's been set forth by ASAM for each of those levels of care. And so sometimes we do have somebody who calls, they are seeking a higher level of care, and we find that they don't meet that ASAM criteria. And then we explain to them, this is what you do qualify for. Is that okay? Yes, it is. Okay, let us get you connected. Here's providers you can contact for that service. When the person goes to that outpatient provider, or goes to that residential or medication-assisted provider, that is when the provider sits down and does the full biopsychosocial assessment with the individual. And so we spend a lot of time making sure that people understand that You know, the assessment comes from the provider level. Here at the access level, we are screening for higher levels of care. If I have a person who calls the main access line and they say, I'm just interested in outpatient services for SUD, again, we are just providing them with our SUD outpatient provider list, or if they have Blue Cross Blue Shield, then we ask, okay, what's your outpatient or what's your insurance? And we have community-based referral lists that we hold behind the scenes because we never want anyone to walk away from us without feeling helped. Our job is to be the public mental health system and to assist people. And so even if the services may not be through us, we want to help point the person in the right direction. So when a person calls and says, I'm looking for outpatient substance abuse services, the first thing we ask is, what type of insurance do you have? Based on that is based on the resource list that we would give them. Many of our outpatient providers are also paneled with private insurances. So a person is able to go to one of our outpatient providers, use their third-party insurance, and again, if that cost is too much, that outpatient provider will make the request to myself at Access asking for funding assistance. Here in this slide and the next, this just goes into a list of all of our providers from the outpatient level to medication-assisted treatment to our residential. I know Tricia as well will post a link to our brochure that also has it as well. One thing that I didn't hit on is I didn't hit on DOP or DIOP, domiciliary outpatient or domiciliary intensive outpatient. Those services essentially is for DOP, it's outpatient services coupled with housing, and the DIOP is intensive outpatient services coupled with housing as well. So it's just essentially, it does differ a little bit than the standard recovery housing. So there are differences in the level of supervision that one might be receiving or the amount of therapy one might be receiving at a DOP, DIOP versus a recovery house. All right, and Tradina, I will turn it over to you unless, Tricia, do we have any other questions that I need to answer first?
Nope, none in the chat.
Great, thanks so much.
All right. So I will kind of pick up where Megan left off, and we'll talk a little bit about some of the other additional services that individuals may contact Access for. The first one here is our adults with mental health services. So when someone calls looking for those type services, that I mentioned a higher level of services, because there is case management that is provided that is not normally provided when you look at mental health services in the community with different private entities. There's psychiatry, there's therapy, whether it be individual or group. They may assist with supported employment, housing assistance, and we have screeners that are embedded in the Oakland County Jail, Hope Shelter, the courts, as well as the Resource and Crisis Center with Common Ground. That's where we're housed. So we have a plethora of different screeners that is also housed there at the Resource and Crisis Center. When they call Access and they're looking for services, as Megan mentioned, they gather the information, and depending on what that individual is looking for and depending on what the need is, they're either scheduled with the appropriate screener, they're placed in what we call our call queue where they'll get a call back later, or as Megan mentioned, they may get a live screening where someone is saying, I have a phone right now, therefore, if possible, can I do the screening now? Because I may not have this phone later. So that is kind of the different options there. So when we talk about how the services are determined, each population, I'll go over the tool that's used. So like Megan talked about substance use, they use in the ASAM criteria. That's the tool they use for that. So when it comes to mental health, adults' mental health, we look at the locus, which is the level of care utilization services. And level of care utilization system, sorry. It determines the medical need for the individual. We can't give someone a service because that's what they're asking for or someone else is requesting they get that. It has to be a medical necessary services. And when I say that, it's kind of like if you're going to the doctor and you're telling the doctor, I want metformin. Why? I want metformin because I heard it takes my appetite away and I want to lose weight. So I want metformin. So the doctor's going to say, hey, but your blood sugar's good. I don't see any pre-diabetes. I don't see diabetes. I can't prescribe you something that's not a medical need. So that's what we look at when we look at medical necessity. Is it something that we see there as a need to support that medication or to support that services? So all individuals, they're thoroughly assessed in our screening tool. We use the level of care utilization system, the locus, and scores are given, and it's based on the times paired with the needs, the recommendations, the level of care, as well as, like I said, the medical necessity. When we look at the locus, there are several areas that we look at. It's actually 7 to be exact. We look at risk of harm, functional status, medical and psychiatric comorbidity. We look at stress level. We look at the level of support an individual have. We look at the ability of the person's treatment and their recovery history. Have they had services before? How did they do with those services? And we look at their ability to be insightful in their recovery status and their ability to engage so that they can work on a better life. Next. So when we look at children with serious emotional disturbances, this is our child services. So it's the same as adults, but it's it's our children. And they're a little bit different, of course, because they don't have level of care there. It's a little different. They look at things like family training, family education. Is very family focused because a child can't function and do things on their own. They have to have their family involved. They live with their family. So the family is very involved with children's services. They look at a therapy, whether it be in the home, whether it be in the office, and they also go to the schools. They look at peer support. So there's individuals that will work with the families that maybe there's teens that have started services when they were really young. They've really done well. They're doing really well in their recovery. And they want to be a support to someone coming in and don't know what to do and how to navigate the system. They have respite because children with serious emotional disturbances can take up a lot of time for parents, and they may need a little bit of respite, a little bit of reprieve, a little bit of break, if you will. That child also may need a little bit of break from that family and from that parent. It also provides psychiatric services, so they will see a psychiatrist and medication can be prescribed if medically necessary. That the ages for this service is 5.5 in school all the way up to 21 years old, which is something that changed within the last couple years. It used to cut off to 18. Then study shows that, wait a minute, we may need to keep them a little longer because just because they have the chronological age of 18, they may not be developmentally there yet. So they may do better with children's services because children's services is very different than adult services. We look at the community, they call in, we do a walk-in, we do screenings over the phone. They may walk into the Resource and Crisis Center. We do screenings in the school. We do screenings with the child. We may ask the child their input on things, but the mom or the guardian, they of course have a lot of additional information that the child may not be insightful enough to provide us. And we look at the CAFES with that, and we'll talk more about that. We have screeners, again, embedded in Oakland County Circuit Court, Family Division, and Michigan Department of Health and Human Services. Next. So we have a service called the Serious Emotional Disturbance Waiver. We call it the SED Waiver. So that waiver, it works with individuals between the ages of 3 and 18 up to age 21. However, you can't call at 21 or 20 to get the services. If you're in the services already, then you can stay a little longer. But if you're past 18, you cannot call for SED waiver to begin SED waiver services. Again, if you're in it, we can keep you a little bit longer. For the SED waiver, you have to have a mental health diagnosis. There has to be a risk for inpatient hospitalizations, past hospitalizations, and just a risk of being removed from the home. The parents have tried everything they can. They do not know what else to do, and I need some additional help. So with the SED waiver, it kind of provides a little bit more than what the traditional SED services will provide. They give additional hours for respite. They may give community living supports to work on some skills. They may give some camp service. They just give more auxiliary services than what they may get in the traditional children's services. The kid must reside in Oakland County for these services. This for the SED waiver, some kids do have Medicaid, but this also, it's a waiver. So let's say it's a family who has Blue Cross Blue Shield, and they have tried all of their community psychiatrists, all of their community therapists. They do not know what else to do. I'm at this point, I don't even know if I can keep my child in the home. I don't know what to do. Well, then the SED waiver kind of waives the fact that they have private insurance, and kind of, if they qualify, kind of gives them the ability to have the Medicaid type services to keep that child in the home, because our goal is the least restrictive environment. And that's what we want to help the child have. That's what we want to help the family be able to support the child in the home. Next. So how are SED services determined? So as I mentioned with adults, there's the locus. So with the children's service, we have what we call the CAFAS. That's the Child and Adolescent Functional Assessment Scale. It determines the level of care that is medically necessary for children. So when it comes to the CAFAS, we look at the day-to-day functioning of that youth. We look at the past 90 days. All children are thoroughly assessed at ongoing intervals in their treatment. So when they come to access, we do a CAFAS. But then let's say they choose one of our children providers, which is OFS, Oakland Family Services, or Easter Seals. They also do a CAFAS at that level as well. And then they do it every 3 months. They will also do one if there is a change in the household, a change in the child. The child was hospitalized. If there's any changes, we need to do a CAFAS to determine where's this change and what is going on. And I need to be able to support, because there may be a change and there may be more services needed. So the CAFAS will support where that need is. Make sure I covered there. So the CAFAS, when I talked about the locus back one more time, Megan. Okay. So with the sorry, I'm saying what I know and then making sure I touch on what's on the slide. So that's all. I'm like, wait, one more thing. So I talked a little bit about the locus and kind of what they look at. So with the CAFAS, they look at how's the child day-to-day functioning. What does it look like in their school? What does it look like at home? What does it look like in the community? What does their day-to-day functioning look like when it comes to their behavior towards other individuals, including the individuals that live in the home with them? What does that day-to-day functioning look like when it comes to moods and emotions? Is there self-harmful behavior? Is there any substance use? Is there any concerns with their thinking ability? That's what the CAFIS looks at. Next. Okay, so under the mental health umbrella, we also have our individuals that are seeking services for intellectual and developmental disabilities, which is our IDD services. So these are disorders that are usually present at birth and that are negatively affect the trajectory of the individual's physical, intellectual, and or emotional development. So with this, that's our kiddos who are diagnosed with ASD or autism spectrum disorder, Down syndrome, cerebral palsy, traumatic brain injury, fetal alcohol syndrome, Willie-Prater syndrome, and the list can go on and on. Sometimes there's things that we get and I'm like, man, I've worked in this network for a while and I haven't heard of that one. And then I may look it up. Different genetic disorders. Those are some of the things that will fall under the IDD category. Next. Okay. So when we look at individuals with an IDD diagnosis, for eligibility, we have to look that this disability was present before the age of 22. So in the previous slide, note that I mentioned that traumatic brain injury is one of the diagnoses that can qualify for IDD. Now, let's say, unfortunately, we have a 24-year-old who gets into a car accident, and as a result of that car accident, they are left with a traumatic brain injury. Unfortunately, due to federal guidelines we follow with the IDD population, that right there wouldn't qualify them because it had to have been a diagnosis that occurred prior to age of 22 and something that they've have had prior and have something they will live with throughout the rest of their life. The individual must have Medicaid insurance or Healthy Michigan for IDD services. And again, like I mentioned, it has to be a disability that most likely will continue indefinitely. We have proper documentation that must be provided. And those documentations, so you guys know, they include paperwork with the medical diagnosis. We have to show that the diagnosis occurred prior to age of 22. So, that can be very difficult. When you think about some of the individuals we may get in the door, let's say they live with their mom forever. Mom unfortunately passed away. At this point, they're 58 years old, and their cousin now has to come in and help take over and try to figure out those are the tougher cases because they have to go and provide some kind of documentation. It just may take a little longer, but we do try to help support them with that. We also need to see the school IEP. IEP is the Individualized Education Program, or the MET, which is the Multidisciplinary Evaluation Team Report. Or we need a psychological. We need to know kind of what's their functioning, what's their level, what kind of testing they've done. If they have an IDD diagnosis, then most likely they will have an IEP. Those have to be updated annually. They will have a MET. Most likely they're updated every 3 years unless the functioning have pretty much stabled out and it's the same. We need a psychological report, most likely, particularly in our cognitive impairments, which is also a diagnosis in those individuals, because we need to look at the full scale IQ. Because if it's someone that falls under borderline intellectual functioning, that one doesn't qualify for an IDD diagnosis. And then a lot of people don't realize learning disability, that doesn't also qualify for an intellectual developmental disability. And very interesting, I like to always point out with this because people see intellectual and developmental disability. This is also some of our physical disabilities as well. So they may, intellectually be smarter than some of us. They're in school, but they may be in a wheelchair. So that is also something that qualifies. There's a physical disability there. And we look at substantial functional limitations here, and they must meet 3 of 7 for our adults up to age 18. And then for our children, they must meet 3 of 5 of those substantial functional limitations. We have some kids that'll come in and they may not qualify, but we'll tell them, come back at age 18, because we look at a broader area at that point. And just so you guys are aware, so I'm going to tell you, just like I informed you guys with the rest of the populations, when I talk about 3 of 5 or 3 of 7 substantial functional limitations, we're looking at, for adults, they're all the same at the beginning. They all look at self-care. So regardless of the age, they look at self-care, their ability to take care of themselves. We look at their ability to learn. So can they learn a skill? Can they retain that skill? Can they apply that skill? We look at receptive and expressive language. Do they understand what is being told of them, and can they express their abilities to their wants, their needs, their desires? For every population, we look at the fourth one is mobility, their ability to walk and move about. We also look at self-direction, their ability to direct their own lives, day-to-day functioning. Those are the first 5. That's what we look at for children and adults. Now, for adults, we add 2 more on, which is 6 and 7. 6 is their capacity for independent living. So you see why that's not for a child, because at that point, they're still children. They shouldn't have the capacity for independent living. So we're looking at, can this child actually live on their own, and do they have the skills to take care of themselves in a home? And then we also look at economic self-sufficiency. Again, for a child, we're not looking at that because they're a child. So they shouldn't have economic self-sufficiency at that point. So we're looking at that for adults, their ability to pay bills, receive entitlements, take care of their economic self-sufficiency. Next. So when we look at this population, again, they're going to call that main access line. They're going to speak with one of the referral specialists, and they're going to collect all the information, tell them the paperwork and all those good things. So that parent may call, or legal guardian may call, and some people actually don't have guardianship of the individual seeking the services. They may be, if you will, their own guardian. So then we'll have to ask permission, if they're nonverbal, for the parent to speak and give the information on their behalf. They ask the questions as we talked about and request the documentation, which I informed you guys in the previous slide. Eligibility will be determined by our Intellectual Developmental Disability Access Screener. If an individual is found eligible, a face-to-face appointment for a screening will be scheduled. And as everyone know, right now we're doing things a little bit differently. So we're doing phone screenings and making it work as best we can. Those screenings are pretty much, they're more in depth. So they're a little longer than our regular children's screenings, which is about 45 minutes to an hour, our adult screenings, which is about 45 minutes to an hour, and our IDD screenings are about 1.5 to 2 hours. Next. So remember earlier I mentioned SED waiver for children who just didn't meet the needs, or didn't have Medicaid but needed a higher level of services. There is a thing under the IDD population that is kind of is a similar type of waiver. So pretty much it's the children's waiver. Right now we have 417 children waivers available throughout Michigan. So openings only occur when a person's, unfortunately, they pass away or they age out or they no longer qualifies, which no longer qualifies usually is not one of the reasons. Now, because someone may have it and they're in another county and they move to our county, that waiver can transfer with them. So each month, the state, they invite children who are next on the list, and the list is a weighted list. It's not first come, first serve. They look at the most severe scores, the most severe needs, and they can bump up someone that has been on the list for years and years. It talks about the score being between 120, 160, and they must qualify that 3 of 5 substantial functional limitations that I mentioned in the previous slide, and they must have severe medical needs. So this kid, they may have breathing machines, they may have feeding tubes and wheelchairs, and they may have some severe medical needs, which is affecting their substantial functional abilities. And as a result, mom or dad, they're working, they don't have Medicaid, but I really need help with this kiddo. Now, there's kiddos that go on this list because it's weighted and because they look at the most severe needs. There's kids that may not have a severe need and they're getting bumped down the list because someone comes in with more severe needs. We've had where they have been on the list for years. Let's say a kid been on a list since they were age 7. Now, at this point, they're 17, about to turn 18. So at 18, they're their own adult. So they can go and apply for Medicaid. They're going to apply for their Social Security. And at that point, they'll have their own insurance. And at that point, they can call and they can request intellectual developmental disability services. So just so you know, if they're on that waivers list, they can stay on that list. And that doesn't mean they'll never be able to get services. They Medicaid will kick in at 18 because they're their own adult. And then at that point, they can apply for traditional IDD services. Next. Don't look like any questions so far. We're good to keep going.
You are good. I don't have any questions in the chat.
Perfection. All right, so let's look here at autism services. This is again another waiver. Individuals seeking autism services, that's 0 to 21. If they get it through us, it ends at their 21st birthday. So they start planning transition 6 months to a year prior. So when they call the referral specialist set them up with a screener who can screen for autism services. They will complete the screening, but they'll also do a couple other tools. They will do an SEQ, which is the Social Communication Questionnaire for children over the age of 4, or they will do a MCHAT, which is a modified checklist for autism and toddlers revised for children between the ages of 16 and 30. So there's a little bit of a gap there because, 4, then you talk about ages 16 to 30 months, because we're looking at, they will do the MCHAT, but we may look at their mental age. So if they're within a mental age over 2, then they'll go with the SEQ, which is higher. But they may be over, let's say they're 35 months. So they're not 4 yet, but they're about 35 months. They can still do the MCHAT. That's something, a clinical tool that the screener will have to determine based on what information they're gathering from the family. So once they do the SEQ and once they do the MCHAT and they've determined that, yeah, I see there's some concerns there for autism. So at that point, the screener will do a referral, and the referral will go and to the diagnosticians. So the diagnosticians, they do a tool called the ADOS tool. The ADOS 2 is the Autism Diagnostic Observation Schedule, 2nd edition. That's the one we're doing right now. And at that point, if they qualify, they will link them to one of the autism providers and core providers. Trying to see. Okay, so our autism, there's a few of our providers that will work with autism services, and that is Easter Seals Community Living Services, Mork, Oakland Family Services, and I believe that's it. Now our autism providers, did I mention everything? Yeah. So our autism providers that we are contracted with is going to be Easter Seals, Autism Centers of Michigan, Autism Spectrum Therapies, Footprints, Behavioral Health Call, Strident Healthcare, Hispanic Autism Services, Jetson Mork Metropolitan Speech, TTI University, Pediatrician Autism Center, or UPAC, and I believe you can find that information on our website. Next. All right. So accessing autism services, again, this is one that requires some documentation to proceed. No documentation for adults, no documentation for children. Documentation for SED waiver, absolutely. Documentation for IDD services, sure thing. Documentation for children's waiver, you bet. Documentation for access to autism services, absolutely. What does the autism services documentation look like? We must know and see that there is a diagnosis of autism. So that can be from a pediatrician, that can be from a school IEP that says autism spectrum disorder is their special ed designation. Long as it's that's fine. They may even have a psychological that has the child already diagnosed with autism. We need that. We need to know that they had a medical physical exam within a year, because we need to be able to rule out there's no medical concerns that's causing this kid not to speak, for example. We also need to rule out there's no hearing concerns and no vision concerns that's also impairing this child's speech. So we need to make sure medically all is good and sound before we move forward with everything else, because that could put the child through something that's very unnecessary. So the hearing and vision, it has to say that it's normal, no concerns, or within normal limits. Kids wear glasses, fine. You would just wear your glasses to the assessment. The family or the doctor say I have a concern, they just need to go to make sure that they're saying they can move forward. With autism services, Medicaid is required. Now, they can have private insurance and Medicaid, but they must have Medicaid. And if they do have private insurance and Medicaid, we need to know what exactly does that private insurance cover? Because as we all know, Medicaid is the payer of last resort. So we need to see what that private insurance cover, and then Medicaid can pick up what else is needed at that point. All right, I think we're good there. Next, Megan. Megan? All right. All right. Any questions so far? Or I can keep moving.
You can go ahead and keep moving.
Cool. All right. So now we have our babies. We have infant mental health. So with infant mental health, we have tools that we use for that. We look at what we call a DECA, which is Devereaux Early Childhood Assessment for Infants, and that's 1 to 18 months. Or we look at the DECA-C, which is the same thing, but it's a clinical form, ages 2 to 5. We also use what we call an ASQ, which is the Ages and Stages Parent Completed Questionnaire that looks at communication, gross motor, fine motor, problem solving, personal adaptive skills, and this is usually normed for children 4 to 60 months. So when we look at infant mental health here, we're talking about early intervention, development, and things like that. So infant mental health recognizes the importance of the infant parent-child relationship to all learning and development. So what they look at is the young child development within the context of the relationship they've had with their primary caregivers and parents. So the services work in partnership with the primary caregivers to nurture protective and secure relationships between infants, young children, and their parents and caregivers. They help the parents and very young children navigate their new and sometimes challenging relationships by nurturing secure attachments and social emotion development that are the foundation for a lifetime of optimal mental health and behavior health. And what happens with infant mental health? They do this by connecting the families with a master level clinician who has specialized training and an endorsement in infant mental health. They set goals together. They work with the families within their environments to achieve optimal health as well as optimal social emotional development of the infant, toddler, and or preschooler. Next. All right. So with all of that, so our IDD providers, we have MORC here, Macomb Oakland Regional Center. We have CLS, which is Community Living Services of Oakland County. We have our children providers, that's Easter Seals, Michigan. We have Oakland Family Service and Arab American Chaldean Council. And for our adults, we have Arab American Chaldean Council again, Easter Seals, Michigan again. We have CNS Healthcare and Training and Treatment Innovations, which is also all on our website. And they're located all across this big county of Oakland to give the individuals choice within where they want to go and make it convenient for them to get to where they need to go. They choose the provider. They're not happy with one provider. They also have the choice to say, hey, I no longer want to go to A provider. Can I please switch to B provider? And we'll talk about where that will occur in a few slides down. Next. All right, so now we have our justice support services. So here we have Ashley Sansom and Amanda Palmer, and we have their contact information here. They're embedded in the community as well as the Oakland County Circuit Family Court. They work in partnership with MDHHS, and they provide services and assist with connecting children and family with services, and this includes youth displaying at-risk behavior in school as well as in the community, youth on probation, as well as adjudicated youth that has been placed in a residential facility that may need assistance transitioning back into the community. Next. All right, here we have Dan Holloway with his contact information here as well. So his position is community-based. He works directly with law enforcement, and he makes sure they receive the necessary trainings that they need. He makes sure law enforcement is aware of diversion options, such as Megan mentioned earlier, SSU, Sober Support Unit, and the OASIS, which is the Oakland Assessment and Crisis Intervention Services for Mental Health. His goal is to work on making sure that they can basically diversion. That's what he's doing. Instead of jail, these are other community options. Let's train and make sure that you guys are aware of these options. Let's train for what you may need to look at and look for when you're in contact with these individuals. Next. All right, here we have Megan Hebert and Heather Willis. Their contact information is here as well. So Heather, she is our adult treatment court liaison for 6th Circuit Court, and Megan is our mental health court liaison for the 45th District Court. Both liaisons work closely with the courts to make sure participants are connected with mental health and or substance use services. They provide ongoing communication between providers and the court, and this includes system navigation, eligibility screenings, crisis intervention, ongoing communication, and troubleshooting between the court, provider network, and individuals served. And again, if you have questions and on how to get them involved with services, their emails are listed. Next. Here we have our Sarah O'Brien and Melissa Gregorio. Melissa is our REACH coordinator, and Sarah is our criminal justice resource coordinator. So they both focus on ensuring that individuals leaving the jails are connected to appropriate services. These services include addressing barriers such as housing, transportation, Medicaid applications, assistance with acquiring benefits, contact information, etc. Next. Here we have Jody Gorenflow. Now, she is our probation mental health systems liaison. Now, Jody, she focused on improving as well as closing the communication gap between the justice system and the mental health system. She also provides training to both systems to help bridge that communication and knowledge gaps. And her information for contact is listed as well. And now, Megan, I will hand this over to you so you can proceed with the rest.
Thank you, Tradina. So Michelle Monfortin, she is our Behavioral Health Systems Liaison for MDOC supervising agents. So starting on April 1, OCHN had taken over the MDOC SUD services. And so she is our liaison that we have hired. She is there to be that point person to identify just any gaps in communication between providers and agents. If something is needed, she's there to troubleshoot what it is. So she just recently came on board. And so we are very thrilled she's taking that over. It is good for me to know that she is, she's that point person for the felony probation officers and then the parole agents. When it comes to PA 511 funding, PA 511 funding still resides with MDOC and everything that was in place beforehand. So at this time, PA 511, it still exists. All of your processes should be discussed with your supervisor for PA 511 because that is not funding that falls underneath OCHN at this time. All right, we also have a Veterans Navigator. His name is Chaka McDonald, and our Veterans Navigator, some of the services that he does is he helps assist all veterans regardless of their discharge status. So it does not have to be a veteran who only has an honorable discharge. It can be any person who has served in the military. It can also be family members of that veteran or children. So he also offers support for military families. Chaka does sit on the district court for Oakland County, the Veterans Court, and helps provide assistance and direction there as well. Chaka also acts as somebody who helps consult with other organizations in Oakland County. Essentially, if someone is a veteran and whether they're trying to determine, do I have veterans benefits? Am I eligible for veterans benefits? How do I even go about figuring any of that out? I've tried calling other places, but I'm not getting answers or callbacks. Essentially, once Chaka is able to talk to the person who served or family member or children, he's able to then say, okay, what is the need? And then he really starts to work either helping to be that bridge between another community partner to say, okay, I have a contact over here, let's get you connected with them. If the person's in need of substance abuse services or mental health services, he's looking at, is it somebody who can come through our OCHN system? What is it they're asking for? So really for a veteran, it is he's helping navigate the entire system for them. Certainly a veteran does not have to go through Chaka. A veteran can call at any time the main access number and discuss with one of our support staff, you know, am I eligible for services? What is the eligibility? This is what I'm looking for. This is what's out here. part of what our referral specialists are asking every person who calls is if they have ever served in the military or if their family's ever served in the military. If they are identifying that as a yes, then we are making them aware of Chaka and that he's there to help assist with resources. And if they want that referral to him, then we're able to make that connection. This is Chaka's contact information. Anybody can call our main access number and request to be connected with him, and the support staff will look at his calendar, get something scheduled for them. And currently right now we're working on a smart sheet referral system that can be rolled out to all of our area hospitals, community partners, because essentially what we know just from working with anybody, if somebody gives me a business card or just gives me a phone number and says, hey, here's a veteran, navigator in the county, call them and they can help assist you with things. I know just for myself, I'll take that and I'll put it to the wayside sometimes. But when I have somebody instead say, listen, I have somebody who could help assist you, will you sign a release? I can provide them with your name and information. Then it's as simple as a community partner taking 60 seconds to fill out an online referral form to us. It comes into us. We have the person's contact information, so we're able to call that person directly. We want to make sure no one slips through the cracks, whether them choosing to not call or anything like that. Maybe it's just anxiety that plagues them with, saying, oh, I don't know if I want to call. But we want to make sure if the person's agreeable to it with a referral coming to us, that we can receive that referral from a community partner and we are able to reach out and follow up with them to see what their need is. And again, we also have our RISE Center. So our RISE Center is Recovery Information Support and Education. They offer, it's a free resource from the community. They offer case management services that are offered on a short-time basis. So if somebody needs to apply for Medicaid, or if they have that third-party insurance that we talked about, and I know that navigating the insurance, just even calling an insurance company and saying, hey, what are my benefits? That can be, one, difficult at times, two, overwhelming. You can end up sitting on hold and then just want to give up and you don't even get that information. So the RISE Center helps assist with all of that. They take it all on and say to person, okay, we know how to navigate it. We can help assist you with getting those benefits for you. And so they really walk the person through every step. And the RISE Center, like when it comes to pulling those insurance benefits, they get that signed release from the person. They do all that coordination with the insurance company, and then they send me the benefits to review when it's someone requesting higher level of care services like detox, residential, or medication-assisted treatment. Trisha, do we have any questions before I turn it back over to Tridina?
Yes, ma'am. If someone doesn't have insurance, should we have them call the RISE Center before calling the access number?
No, that is not needed. A person who does not have any insurance, they can call the access number first. And we're able to service them. We have a very large, and forgive me, I might misquote this right now, but our income guidelines, they are very broad, if you will. I believe for a family of one, that you need to at least make $68,000 or below to be able to qualify for some part of funding assistance. Now, if you are at the high end of that $68,000, it's a family of one, you may have co-pays that come out of that with no insurance. But also providers are able to look at, and if somebody, even if they're making $68,000, it's a household size of one, the provider, if a person is saying, but I still can't afford that copay, the provider says, okay, let's talk about your bills and do a little more of a deep dive, because it can be someone who, if they're involved with the criminal justice system, They have court fines. It could be someone who's divorced and has child support payments that come out. And then there's regular bills. So just because somebody does have that high income of closer to $68,000, it doesn't mean that money's always readily available. The provider will do a deep dive, and then if they're able to waive copays, they'll submit a waiver to us on the back end. When a person goes to a provider, if they have no insurance in terms of SUD services, when they go to that SUD provider, a couple quick things I do just want to add on real quick. So all of our SUD providers are co-occurring capable, which means for someone who has mild to moderate mental health symptoms, for someone who has just the standard type of anxiety, their mental health does not rise to the level of severe and persistent, where they may need to it may need to be looked at to see if they qualify for higher level of care mental health. That's when we're looking to see, do they qualify for one of our core providers. So when it's standard mental health, all of that can be addressed at the outpatient provider, and they're co-occurring capable. They're able to address the mental health needs. They have a psychiatrist on staff who's able to look at, do we need some, mild medications that would help assist the person? So that's always very good information to know as well. When a person also goes to that outpatient provider, they're going to have a case manager and a peer coach that can help assist them. So when they go to that outpatient provider, even when we have someone that goes to a higher level of care provider, the case managers, for someone who doesn't have insurance, they're going to help the person apply for insurance. So to call Access, if someone's looking for outpatient, and say, who are your providers, they don't have to go through the RISE Center first. We help give every person who calls us, we help give, we have to go through a lot of steps and ask them a lot of questions. If there's follow-up things needed, like paperwork or their benefits, we really walk each and every person through, this is the next step that needs to occur. Let's get you connected with the RISE Center. And so we are really making sure that if a next step is needed, we are getting them connected immediately to that next step, because we are the public mental health system. We're here to service everyone as best as possible and ensure they don't slip through the cracks anywhere. All right, Tradina, I turn it back over to you.
All right, so let's wrap this up with talking about our crisis services. So Common Ground's one of our providers that we contract with. They are housed at the Resource and Crisis Center with our department, and they have this awesome crisis line, which is listed here. 365 days, 24 hours, 7 days a week. You can contact them. They'll assist. They also are able to take text messages on that line. I believe that's Monday through Friday from 4 to 10 p.m. Then we have our Oasis, which we mentioned a couple of times, and they provide recovery-oriented face-to-face assessments, crisis intervention, and stabilization services for all Oakland County residents, including children. You also have our OCHN team here, and they are our Oakland Crisis Intervention Team, recovery team, and there's professionals that meet with individuals that provide crisis intervention, and that's face-to-face. During this time, things are a little bit differently, but normally it's face-to-face. They go to the emergency rooms. Individuals that come to the Resource and Crisis Center, they may go to individuals' home, and their role is to provide supportive services to the individuals up to about 30 days to assist them to connect with the providers. So someone comes in, they don't have services, they're in crisis, they support them through, and they stay there with them until they're connected to one of our providers, Easter Seal, CNS, TTI, OFS, things of that nature. Then we have this other cool resource here, our Victims Assistance, and they assist victims of crime as well as survivors of human trafficking. And when I say victims of crime, that's homicide, loss, sexual assault, abuse, domestic violence, assault, robbery, etc. And again, they can be reached at that main number as well. Then they have the legal clinic. So what's really cool about this is anyone seeking legal assistance, they're welcome to call the main number there, and they can get set up with having some on-site confidential consult with a legal provider. They will help. They won't direct represent, but they will give referrals. They will help assist in whichever way they can. And this service is free, so that's really cool. And we have the crisis response unit, which we mentioned a couple times. That's there at Common Ground, the Resource and Crisis Center. So they provide adults with short-term voluntary psychiatric and substance use care, which includes medical supervision, nursing, therapy, discharge planning, and they assist with getting them connected as well. Then we have our sober support unit, which we talked about as well, open 24/7. They can come in to Common Ground, and they can be housed there until we get them connected with services as well. Next.
Tradina, we do have a question.
Oh, okay.
If mental health concerns are mild to moderate, is access, would that be the number to call for services?
You can call us. They may ask a few questions. The referral specialists. Now, I may note the referral specialists aren't clinical, so it may very well that individual will call, and if they go for and they put them in for a screening with one of the clinicians, they may put the person through a screening process. But our clinicians are really good with kind of asking questions, prompting questions to make sure that this person should be screened for services. So we won't put them through that 45-minute to an hour screening just to tell them on the other end that you didn't qualify for services. So they may ask them a few questions at the beginning to just see what level. We do have crisis resources by insurance, by location. So what that is we have a list of individuals who will take different Medicaid HMOs, different private insurances that individuals can go to still get those mild to moderate services or needs met. So you can't, bottom line, yes, you can call, and they will help the person navigate. That's the easiest way, is to just have them call. Sounds good, Michelle? Guess so. All right. So customer service. So I think earlier I talked about someone that may say, man, I'm with this provider. I just feel like it's really far from my home. And I just found out it's one really 2 blocks up the street. I really want to make a switch. They can call customer services for that. They link individuals to services. They help navigate the system. They help with problem solving and individuals that's not satisfied, people that maybe were closed and it's been 6 months that they've been closed, and now I'm like, oh, I probably need to call back. I need to get connected. They can get the individual relinked, reconnected to services. That's our customer service. That's their number on how to contact them. And if you need customer service and you then come to find out you need access, they'll transfer you guys to access. And if you call access and we determine that customer service will meet your needs, we can transfer you to customer service. So you will get your needs met regardless of which number you call. Next. Here is our contact information. There's Megan's name, number, email, as well as my own. Here's our main access line. Our numbers, I would say, is meant for you, the professionals, of course. And then there's the main access line that anyone can call. Megan, you have any additional things you want to add before we see if there's any additional questions?
No, I think really the best takeaway, for everyone is that at the end of the day, please always feel free if you have someone and there's ever an uncertainty of, well, who should I have them call? You can have them call us, because we're going to help them navigate. They may or may not qualify for that screening, or they may not need a screening, you know, based on what they tell us during those initial questions. But we will help assist anyone who calls. So at the end of the day, we're here to assist.
Agreed.
Great. Thank you, Megan and Tradina. If you have any additional questions, please put them in the chat, or feel free to unmute yourself and ask Megan or Tradina your questions. I am working on uploading the slides right now to the chat. However, it's a very large file and it's giving me an error. So if I'm unable to do that, I'll make sure that I will try to email out a link when the recording is ready on our website. All right. Well, I don't see any questions. I don't have anybody unmuting ourselves. So I am going to go ahead and end the recording here, and we can stay on for a few minutes if there's any last minute questions.
Perfect. Thank